PC.
Excellent.
Okay.
Everybody will have to hit the continue button when the question comes up about recording, because it just needs to make sure that you're okay that it's being recorded. But after that, we're good to go.
Okay.
Thank you, Marie.
All right. Thank you. So I'll let these few last people, and Tyler, if you see anyone that I don't, you can admit also. So hello, everyone. We're happy you joined us today for New Knowledge Adventures, another one of our wonderful classes today. If you haven't attended one before, thank you for taking the challenge and coming in watching this on Zoom, since that is the way all of our classes are going to be this year. And also we have Tyler Jepson, that's who is going to be putting on the class today. So letting you know that he said it's fine if we have questions asked along the way. You can either put those in the chat window, or you can raise your hand somehow and let us know that you'd like to ask a question, and we'll be glad to let that be part of the presentation too. So I just want to tell you a little bit about New Knowledge Adventures, and this program is over 15 years old at this point. There's a lot of dedicated volunteers that help put this on. And it all began in Pocatello with Idaho State University. And then also it came up to the Treasure Valley and began here. And we had Treasure Valley YMCA get involved also. So this has been a partnership since 2014. And we do have many people involved in putting this together. I happen to be on the curriculum committee, so if you think of any classes or you know someone who would put on an interesting presentation, we would love to hear from you and see about maybe adding that to our fall quarter. Naturally, since we are in the time of COVID, all of our classes are on Zoom now, and may be the same way for the fall. We'll see how it goes for this year. Just want to let you know that Tyler is also a volunteer for us today too. This is anyone that you find that will put on these classes and gives of themselves. And today he's giving us his time and his knowledge. That's a big part of our group. So you probably read a little bit about him on the, possibly on the site that shows the class itself. So I'm going to let him tell a little bit about himself. I'm just going to briefly tell you that he's worked in a variety of outpatient clinic settings. And he also deals with a few different diverse specialties that have a lot to do with the geriatric group, which we all are beginning to fall into, let's say. So maybe he'll have plenty of questions for you, and he'll be able to explain to you the things that he has found along the way. So I think I'll just have him begin. And like I said, if you would like to ask questions, feel free to let us know, or put them in the chat and Tyler will answer them along the way. So go ahead, Tyler, and you can give a brief scenario on your background so that everyone knows what your specialties are.
Sounds good. Thank you so much. I appreciate you guys having me. I always enjoy having these talks and connecting with people. That's probably one of my favorite things about being a physical therapist, is that I get to hang out with really fun and interesting people all day long. And therapy tends to happen when people have fun. Better therapy happens when people tend to have fun. So I try to have as much fun as possible. So one of my specialties is I'm a board certified geriatric specialist. Within the field of physical therapy, there's a variety of things that you can become board certified in, and geriatrics happens to be one of them. And within that specialty, I found myself being really fascinated with this other kind of subspecialty of vertigo and vestibular disorders, so inner ear problems. So many of my patients over the years have included individuals that have gotten joint replacements, had back aches, back pain, whether it was from an injury or just something kind of crept up from nowhere, and then also dealing with a lot of individuals who've had a lot of imbalance problems because of dizziness or because of numbness of their feet, neuropathy, or sometimes just plain old deconditioning because of we're seeing a lot of hospitalizations due to COVID. Many of these individuals, even after their COVID goes away, they're very impaired because they're so out of shape and they're so deconditioned from just being bedridden from the COVID that they need a lot of help. And so I've had some experience with those pre-COVID, and I've been teaching for, at the collegiate level, I've been teaching since about 2015, and full-time since, I've been teaching at the collegiate level since 2009, excuse me, and then full-time since 2015. So one of my favorite things is having students in the clinic with me, because I found that the patients really enjoyed having the explanation I would give to the student. The patients would really, perk up and listen to. And I found that, the more that they understand about what's going on with their bodies, their conditions, the more likely they were to engage in physical therapy. And so that kind of really helped, push me more towards education. So this is a perfect mix of physical therapy and education. So I really enjoy doing anything like this. I'm fairly informal, so feel free to raise your hand. You can try to, if your camera's on, you can wave it at me. Hopefully, I should be able to see it. Or you can hit the hand raise button on the reactions bar, or there's a little button called reactions, and there's a raise hand icon. Even if your camera is not on, it'll bring you to the top of my Zoom so that I'm more likely to see it. Yep, just like that, Marie, perfect. And or you can just turn on your microphone and interrupt me. That doesn't bother me. When I had this talk, 2 years ago, I want to say 2 years ago, there was a lot of really great conversations and a lot of people like, hey, what about this? Which then stimulated other questions, which I'm all for. So feel free to shout out at me anytime you like. Okay, I am going to share my screen, and I'm going to do a fun little thing where I like to insert myself into the screen. I have to kind of figure out where to position myself though. Okay, that way you can see both me and my information on the slides at the same time. Well, looks like there's some questions in the chat, but looks like they're not addressed towards me, so I'll let someone else handle those. All right. And if at any time you can't hear me or tell me to speak up, I will try to do my best. Just let me know. All right, here we go. So some of the things that I want to talk about today are, what are the effects of aging? And I mostly want to contrast normal aging with pathological aging, because normal aging is a relatively normal and actually a very gradual process. And one of the most common things that I would hear in the clinic while working with patients is, oh, this is because I'm just getting older. Sometimes that was true, but more often than not, it wasn't true. That, this is my problem wasn't necessarily because of normal aging. It was more because of pathological aging, which is more associated with disease and disease conditions, which I'll talk about a few of the overarching, kind of broad strokes in most common diseases. So I mostly want to compare and contrast those two things. And then I want to talk about what we might actually do about those in a physical therapy setting, and what that might look like if you need help outside of physical therapy. Because very frequently I will pull in my coworkers who are in other disciplines so that they can also help me. Okay, so normal versus pathological. Oh, here I am, I'm in the way. I'm gonna make myself smaller there. I talk with my hands a lot sometimes, so sometimes it's useful to have me in the picture. When I'm teaching to my students, sometimes I actually have to have hand gestures in order to convey what it is I'm saying or show what I'm doing. But what's interesting about the normal aging process is that it really is a very, very gradual process. It starts at about age 30, so pre-30, typically individuals are gaining. They're gaining muscle mass, bone density. Their bodies are still, for the lack of a better term, they're still developing up until age 30. Once they hit age 30, there's this very, 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 very gradual decline between 30 and 65. What that normal aging process, when it's not interrupted by any other diseases, really you can't see an appreciable difference in someone's physiology or their physical performance until about the age 65. Now, if you introduce a disease process, into that person, you're probably going to see some deficits much earlier than 65. But when we look at the research, we see that it's actually not until then that we actually start to see or notice that gradual decline. Now, there's not to say that you can't reverse the decline. There's actually many situations where you can flatten the curve, or even, you can actually gain strength. You can gain strength in your 90s. And so you can actually make, I don't want to say the aging process, but the effects of the aging process, some of them actually are reversible to a certain extent. So here's an example of some very common pathological or pathological sources of aging disease. Hardening of arteries due to smoking tobacco, which can lead to decreased circulation, which can lead to heart attack or stroke. And any one of those things will cause aging or an acceleration of the aging process and lead to a certain number of deficits within that person. Another example is wrinkles due to sun exposure. The sun damages our skin, and it damages the nice elastic fibers that kind of keep the skin nice and tight and firm. And those fibers tend to degrade over time, especially when exposed to UV rays. They relax, leading to skin that tends to wrinkle as opposed to spring back in its elastic fashion. Well, what is aging? So there's actually quite a few theories about aging. We don't necessarily know all the processes involved in aging, which seems like kind of an odd thing for science today. But one basic definition of aging is at the top there. It's the accumulation of changes over time. Aging is a normal process. Aging should occur, especially you're thinking about a child or a baby or even a teenager. There should be changes and there should be development. And so even after the age 30, we're seeing some very normal physiological phenomenon occur. I won't get into all the different theories, but there's a few theories out there as far as why do we age? One of them is redundant systems. So what's interesting when you look at our DNA, there's codes. It's like a recipe book. Our DNA is literally the recipe book for all the components of our body, all the proteins, all the amino acids, et cetera, et cetera. Our DNA has multiple pieces of code that are identical to each other. They're exactly the same, and they're repeated over and over and over and over again. And that's a good thing, because when you take a photocopy of a photocopy of a photocopy of a photocopy, that image tends to degrade over time the more you copy it. The same thing happens with DNA. Whenever our cells replicate, we have to duplicate the DNA within it. And little tiny errors can sometimes occur within that duplication process. And then those errors are permanent, going forward. And then more errors are added on top of it every time there's a mistake in the duplication process. One of the theories is that, it's this accumulation of errors in the copying over time that leads to aging, disease process, et cetera, et cetera. There's a few others as well, but they do think that a certain amount of genetics is involved. Some of it may actually be pre-programmed into us. There may be a certain lifespan for certain cells that they are genetically programmed to only be able to divide this many times before they die. Whereas there's another theory that says, oh no, it's accumulated damage that occurs and accumulates over time that eventually leads to cell death. My opinion, just like with many other things, it's probably multifactorial. It's probably a combination of all of those things. And it may not be one thing, it's many things, which makes something very difficult to study when 10 different influences can affect the situation one way or another. Other terms I might use, aging is a spectrum. So you might hear me say the young old, the middle old, or the old old. I can personally tell you, and I'm sure you all have met an individual who is, let's say 40, who may look or even act like they are 65. Or I have actually worked with some amazing individuals in the Ontario area, Ontario, Oregon, very large farming community. I would have patients with balance disorders come in after pulling a bunch of irrigation hose in the middle of a field by themselves next to, a 5-foot ditch. And then they come into therapy for balance. It's like, you have pretty good balance as it is. But these, I worked with a 95-year-old gentleman who was probably one of the most physically fit patients I had saw between the ages of 40 and 90. And he was 92. And he was more physically fit than, probably most adults, period. It doesn't matter what their age is. And so just because you have this age associated, or this number associated with your age, it doesn't necessarily mean anything. But we do categorize, based on this age range, because we do see some tendencies in the young old versus the old. Their bodies are physiologically different, between the ages of 65 and 75 versus someone who is over the age of 85. Generally, we can say that these two individuals have fairly different, physiologies. It's not always the case, but that tends to be true. Okay. So this second bullet point, or this bottom bullet point here, kind of has to do with that theory of aging and that redundancy system I was talking about. When you look at a system with multiple redundancies within it, what's interesting is that if you can make it to a certain point, 65, you're actually very likely to make it to the age of 80. If you, and it has to do with, math. I'm not going to go, I don't necessarily always understand the math to it, but it's kind of like this logarithmic, curve. But the statistics are there, and they actually do show that, individuals at 65, very likely to make it to 80, which is interesting. So physical therapy in general encompasses these 5 bullet points. I am able to have an effect on anything within these realms: musculoskeletal, so your bones and your muscles; cardiovascular, your heart and your arteries; pulmonary system, your lungs. Physical therapists actually do quite a bit of pulmonary therapy. Neuromuscular system, brain, nerves, and how they interact with your muscles and your other sensory organs. And then your integumentary system, which is actually your skin. One of the things that physical therapists specialize in is wound care, wound management. And so I'm only going to be speaking about these things. There are many, many other body systems that are affected by age in a different way. I'm just going to give you some, general overviews of these 5 in particular. So the first one, musculoskeletal. We do see a decrease in strength, but as I said, after the age of 30, we do see a decrease in strength if the person isn't really, trying to, get stronger. If someone goes out of their way to get stronger, they can increase their strength well into their 90s. We've seen that over and over and over again. That's easy, that we know that for a fact. But all things being equal, if someone is just kind of living their life, we do see a gradual decline from 50 to 75 years with some, moderate exercise. Without exercise, that decline is increased. And so they lose 1% per year, which would be the equivalent of 20% between the age of 50 and 70 years old. So 1% doesn't really seem a lot, when it's 1 year after year after year, but after 20 years, 30 years, that can be a lot of, there can be a lot of weakness present. And that weakness, that deficit of strength, can be the reason why some people are unable to live in their homes by themselves. They're unable to get up off the toilet by themselves. That's a bad day. We don't want that to happen. Exercise can easily reverse this trend towards losing muscle mass. What's interesting is that the muscles that are going to be most affected by age, the muscles that you're going to lose first, are the muscles that get you up off the toilet, are anti-gravity muscles. So if you touch your thighs, you're touching your quadricep muscles. Those are big, large muscles, and then your butt muscles, your gluteus maximus. Those are also what we call fast twitch muscle fibers. They're designed to act very strongly in a very short period of time, relatively short period of time. Standing up from a chair, they only have to work for, hopefully a couple seconds, and that's it. And then they can kind of, take a break again. Climbing a stairs, one leg, fires and pushes you up one step, and then the other leg does the work, and the other leg does the work, and it rests in between. Unfortunately, it's those muscles that are affected by age the most, and they tend to weaken the fastest. And so we do see a lot of deficits, mobility deficits, walking deficits, and then people being, like I said, unable to live on their own because of that weakness. Let me move myself out of the way. And so the bottom is just kind of a plug for physical therapy or physical activity, really, in general, because it doesn't even have to be therapy. It doesn't even have to be exercise per se. Use it or lose it. That's kind of the name of the game with the musculoskeletal system. So even people that are severely, severely ill can actually benefit from exercise. There are many studies illustrating we can actually get therapists, physical therapists, occupational therapists, we can actually get people out of the ICU faster, sometimes by 1 or 2 days. And 1 or 2 days doesn't seem like a lot, but the cost of being in the ICU is astronomical. And then the side effects of laying in bed all day long are actually pretty detrimental in the long run. And the sooner we can get people out of bed and prevent them from being bedridden, the sooner they can recover. So even people that are catastrophically ill, such as in the ICU, can actually benefit from physical therapy. I frequently show videos to my students of someone who just got done with open heart surgery, has a vent, has tubes in his chest, IVs, catheters, you name it, these things coming out of him, ports. And they show him getting up and doing, kind of like what looks like squats, like mini squats in front of his bed. And even that little tiny bit of exercise can actually just get things moving again and increase the healing process and benefit the person medically, not just their musculoskeletal system, but they will heal faster and they will recover from whatever surgery or event that occurred. One of our favorite terms is motion is lotion. So we have cartilage, tendons, and ligaments, which is, collectively we call it connective tissue. And typically this connective tissue is very elastic. Oh, I should have had a rubber band with me. I didn't prepare very well for my lecture today. So if you imagine a rubber band, a young rubber band is nice and elastic, and it springs back and it goes back to its original shape very easily and very quickly. As the rubber band increases in age, it tends to become a little bit more stiff and a little bit more brittle, and so it doesn't kind of recoil nearly as well as it used to. And that can actually have a huge impact on balance and energy consumption. And I'll talk about the energy consumption in a little bit. But a lot of our balance, like if you stand me and I stand on one leg and try to balance there on one leg, a lot of my balance is actually a byproduct of this elasticity of all of my tissues. When I can rely on the natural elasticity of my tissues, my muscles actually don't have to work as much, which ends up conserving energy. And it also provides me with much better balance because the elastic recoil of my connective tissue is immediate. I don't have to think about it. I don't have to tell my brain to tell my muscle to contract or relax or whatever. And so this natural elasticity is actually a very protective thing for our balance. Unfortunately, as time goes on, we tend to lose that gradually. Now, there are some disease processes that will accelerate the loss of that elasticity, especially things like chronic inflammation, usually associated with smoking, dehydration, poor diet, etc. The second one, arthritis. Arthritis is one of the most common musculoskeletal disorders out there, and it is not necessarily directly related to age. You can take an x-ray of most 20-year-old, people in their 20s, and you can actually find some form of arthritis somewhere. You could also x-ray a bunch of individuals who are 85 years old, and you can identify quite a few joints that don't have arthritis. So arthritis doesn't always necessarily correlate directly with age. We do see it more often as we get older, and that has to do more with kind of the wear and tear. But what's interesting is that bad wear and tear can lead to arthritis. Good activity, good physical activity can actually lubricate that particular joint and prevent the arthritis from getting worse, and actually alleviate some of the pain associated with that arthritis. So like I said, one of our favorite terms is motion is lotion. And that actually applies to the muscle, the tendons, the ligaments, as well as the joint surfaces themselves. One of the analogies I use is you have cartilage on the ends of so this is my knee joint. You have cartilage on the end of each bone. Wherever bones are near other bones, they're going to be covered in cartilage. That cartilage is almost like an oil-soaked sponge. Whenever you compress that sponge, or squeeze it, it squeezes the oil out of it and it lubricates the joint. As time goes on, the sponge tends to get worn away to a certain extent. And so maybe the sponge that's immediately in between my two bones is kind of getting worn away, but the sponge that is kind of on the other sides, kind of adjacent to that congruent surface, is still perfectly intact. So when I bend my knee, I'm squeezing the oil out of the intact piece of the sponge and spreading that oil throughout the entire joint, thereby lubricating the entire joint surface, which tends to relieve pain associated with arthritis. And then there's also the effects of, increasing the strength of the muscles that actually move that joint and all the other things. So we want people to move. And it seems a little counterintuitive when you think about, well, it sounds like too much motion caused my arthritis. Shouldn't I rest my joint? And the answer is yes and no. Yes, we need to rest it when it requires rest, but if it rest it too much, it's gonna get stiff, it's gonna get weak, and it's actually gonna be worse in the long run. Movement is better in the long run, even if it is a little bit uncomfortable in the moment. That's when you talk to your doctor, talk to your physical therapist about, okay, how much is too much, how much is not enough. Okay. This part, this is probably one of the most common or one of the most frequent places we can get arthritis. Many therapists get arthritis at this joint and actually have to have this joint replaced because we work with our hands a lot, and I can speak to that. It's one of the things I love about vestibular therapy is that I don't actually have to do as much with my hands, and it can protect my joints a little bit better. So this, I kind of already spoke about this. Osteoarthritis is the traditional arthritis that you think of. So you may hear the word OA. OA refers to osteoarthritis, as opposed to rheumatoid arthritis. Rheumatoid arthritis is a completely different animal that actually has an autoimmune component to it. And that acts a lot differently than our traditional arthritis that we're talking about here. So in general, what tends to happen, I kind of summarized already in my chart down here. There's cartilage in between the bones. The cartilage tends to wear away, and then you literally have bone on bone. And so that bone on bone situation leads to the osteoarthritis. That's pretty uncomfortable because it's kind of like rubbing sandpaper against sandpaper eventually. Anyone with arthritis usually can attest to the fact that you get that grinding and that clicking and that popping. And that's because you have fairly rough surfaces rubbing against each other. And that's one of the reasons we have joint replacements, is the doctor comes in and smooths that out, puts a nice, almost friction-free surface on there, like Teflon and metal. And all of a sudden it's perfectly smooth joint surfaces again. And usually things are a lot less painful eventually. Bones. So let's talk about bones since we're at the joints. Your bone mass tends to increase until about 30. And then it gradually, just like I talked about before, it gradually starts to plateau and then decline after the age of 30. Now, if you're someone who's lactose intolerant or doesn't consume enough calcium, your bone density is going to get worse a lot faster than that. There's another dip, especially for postmenopausal women, after they experience menopause. Estrogen helps with the absorption and the utilization of calcium. Menopause usually means a drop in estrogen that's available, and we do see a drop off in their ability to absorb and use calcium, which leads to decreased bone mass. Men will also eventually experience a decrease in bone mass as well, but it tends to be a little bit more gradual and it tends to be a little bit later in life. So here's a chart with that. And they say this to many young women: what you put in your body now, referring to when they're teenagers, really has a huge impact on you when you're 30 years old. So if you started out your teens as really poor bone mass, then at 30 you're probably not going to have great bone mass either. So it's not just diet though that actually impacts bone mass. So calcium and vitamin D are definitely major components of that, and so frequently those are prescribed by doctors and dietitians to make sure you have as much bone mass as you can possibly get. One of the other biggest factors of affecting bone mass is stress on the bones. If you ever heard of astronauts will actually get osteoporosis. And if you ever see them like running in space or running on a treadmill in space, that's actually one of the main reasons they're doing that, is actually to prevent these relatively young astronauts from getting osteoporosis. And they get osteoporosis because when you're in space, you have no stress on your, see my dog, every once in a while you'll see a picture of my dog. That's my dog. She passed away about this time last year. So when they're in space, they don't experience the stress of gravity on their bones. And so our bodies are actually extremely efficient. And if you have extra, your body is going to say, well, you don't need really dense bones because you're not ever using your bones because you're in space and there's very little gravity. So your body will actually start reabsorbing the bone and will recycle the calcium in your bone and use it for something else. Calcium is actually extremely important. It's actually more important to our neurological system than it is to our bones. It's really interesting. Our bodies will steal calcium from our bones because our bones are actually kind of just a storage shed for calcium. Calcium helps make our bones stronger, of course, but it's more important for our nerve fibers to function as opposed to osteoporosis. So if you don't have enough calcium, your heart will stop beating. That will eventually happen. And so your body will steal calcium from your bones. That's what it's designed to do. But so these guys in space and women in space have to kind of strap themselves down and run, and they actually have to kind of mimic the effects of gravity by putting stress on their bones. If you take an X-ray of these individuals who do karate and they break boards and they break bricks with their hands, if you take an X-ray of their fists, you will actually see their bones are way, way more dense than the average person because they spend all day, every day, stressing those bones. And when you stress a bone, you actually can cause microscopic damage to the bone, and the body will then come along and reshape that bone and create a stronger version of that bone, given enough time. And that's what actually exercise does. If you are exercising on a very regular basis, the strain of your muscles, the strain of pushing the weights, pulling whether it's your body weight or even weights or rubber bands or whatever, the stress of doing physical labor increases the density of your bones. And it's one of the things that we really prescribe a lot for individuals who are at risk for osteoporosis. And I'll show you some examples of why we might do that. So there's two different kinds of bones. This is what we call like spongy bone. This is the inside. If you cut a bone in half, if you ever like, looking at a T-bone steak or some other bone, wherever, you see kind of these, just trabecularly, there's spaces in between the bone. This is like the rebar inside of concrete. This is what gives bones the flexibility. Bones can actually bend to a certain degree. Little kids' bones bend a lot because they're still mostly cartilage, and so they're really bendy. As we get older, though, and this spongy bone is surrounded by a shell of relatively closely compact bone. So spongy bone and then compact bone. The compact bone is very brittle. It's very strong, but it's very brittle. So it's kind of like the cement in the concrete, and then the rebar is like, this spongy bone. You need both of them to have a bone that's both strong and flexible. As time goes on, and if you were to get osteoporosis, this bone tends to disappear first. And you're left with very, very hollow, kind of brittle bones that break and fracture very, very easily, which is not what we want. So this is that, that compact bone. This is that hard outer shell. And then the spongy bone here on the bottom is usually what's on the inside. And as time goes on, you see both tend to disappear. Because again, the body's going to rob the calcium from the bones to use elsewhere. And that's one of the reasons why the doctor gives, so much calcium supplements, is because we actually need the calcium for other things. We just happen to store it in our bones. The calcium is needed for strong bones, of course, as well. So if you can keep up your calcium intake, then your body will be much less likely to steal it from your bones. If individuals are breaking bones by simply having what we call ground level falls, so if I'm standing and I just fall over for whatever reason, if I break a bone because of that, that's a red flag. Chances are there's probably some brittleness in that individual's bones, and you're going to want to get a bone density test done in that situation. Now, there are exceptions, but our bones should be strong enough to withstand, falling over and landing on the ground. Now, falling from, a two-story building, that's another matter. That's definitely going to break bones. But, standing, falling over to the side shouldn't really break any bones. If it does, get checked out. Another red flag is actually getting shorter very quickly. So they say a loss of over 1 or 1.5 inches in a year is usually indicative of a compression fracture in your spine. And I'll show you a picture of that here in a little bit. Now, this doesn't necessarily apply to young people. What's really fascinating with young people, so like people in their 20s, is they will be an inch taller in the morning compared to the evening. And that's because the discs that are in between their vertebrae, the bones, their discs are very, very well hydrated. So in the morning, disc is perfectly well hydrated, but then as the day goes on, gravity slowly squishes the water out of those discs, and a person in the 20s will actually lose about an inch in height, or can lose up to an inch in height, morning versus evening. That's a normal thing. That's not pathological. That's actually supposed to happen. As we get older, though, one of the common themes that we see with our bodies is that we lose the ability to hydrate our tissues. Our tissues just don't absorb nearly as much water as they used to. And so as that person goes from their 20s into the 30s, into the 40s, and et cetera, their ability for that disc to reinflate with water is decreased until eventually, you do get shorter over time naturally because of that dehydration of the disc. And so what I'm talking about with bone mass doesn't, really apply to that. We're talking about this. So I kind of skip forward a little bit. This picture on the left here is a cross section of the vertebra. They're like blocks, inside of your spine. And you can see that trabecular bone really well inside of here. And so the one on the left maybe looks a little bit dense compared to the one on the right. This one looks relatively hollow. and it's literally just been squished. So that's what we call a compression fracture. And this, this woman on the right side here, she has probably experienced multiple compression fractures in adjacent vertebrae. So she is, if you measured her height, she's well over 1 inch shorter than she would have been if she would have the ability to stand up straight. She is standing up straight. She doesn't have the ability to straighten her spine any more than that because of how her vertebrae are now physically shaped. And so we see this curvature, which is very common. We call that kyphosis. It's just we normally have a little bit of kyphosis in our upper spines, but it becomes very accentuated when you have a bunch of blocks that, instead of being square, they become triangular shaped or wedge shaped, and you stack these wedges on top of each other, and it forms that, that arch, that curvature. Okay, so like I mentioned, if an individual, if an older adult loses 1 inch or more in height from 1 year to the next, that probably is indicative of a compression fracture. So, or if all of a sudden they're slumping before and then they weren't a year ago, that might also indicate it. So if we see that happening, we as physical therapists are thinking osteoporosis. Okay, we can do something about that. We can A, prevent it from getting worse, and B, we can potentially make it actually better. Can we reverse the curvature of her spine? Probably not, but we can help prevent her from getting more and more hunched over, which will happen if the disease process is allowed to continue. Have you ever heard of Tai Chi? What's amazing is that there's actually tons of evidence out there for Tai Chi. Tai Chi is amazing at preventing balance disorders and falls. It can actually also be very good at increasing the bone density in certain parts of the body when done on a regular basis. There's this natural tendency for people to look for the magic pill, though, literally the magic pill or the magic bullet. And you've probably heard of like Beniva, Fosamax. These are medical treatments for osteoporosis. Some of them can actually be very effective, but I forget which one it was off the top of my head, but they pulled one from the market years ago because they found that while it increased, and I could be flipping it, you may have to correct me if someone knows, it increased the density of the spine, but it decreased the density of the hip. Well, I may have flipped it though. So even though it made one bone denser, it actually made another bone less dense, which led to fractures in the other bone, which we don't want either. So the point of that story is that medication can be useful, but we can't always rely just on medication for some of these things. We have to approach these disease processes from multiple angles: medical, physical, etc. Oh, someone's at my door. My dog is going to bark now. Hey, don't bark. You're okay. Here's my dog. My vicious guard dog. He sits in my lap. He'll be quiet. So along with loss of bone mass, which is called osteoporosis, I think most people are familiar with that term, we can actually lose a lot of muscle as time goes on as well. And we call that sarcopenia. Sarco means muscle, whereas osteo means bone. And then penia, that part of the word penia means lack of or shortage of, I forget off the top of my head. But oftentimes individuals who are having decreased bone mass are also experiencing decreased muscle mass. Tends to also be associated with increased falls, increased fractures, and other disorders or disabilities, such as not being able to be mobile on your own. So maybe a wheelchair or a walker, cane, etc. Same rule applies though: use it or lose it. If we increase the stress that we put on the muscles, then we can actually make those muscles bigger, stronger, Those muscles in turn will pull on the bone, and the muscles can actually help the bones become stronger as well, which is what we want. And then the overall effect is that the person becomes more mobile, more independent, and they don't have to be admitted to a skilled facility or require help from other people. So I like to say, though, no little pink weights. You've all seen those little pink weights that are like 1 pound, 2 pounds. Those don't do as much as you think they do. It's better than nothing, but we have to engage what we call the overload principle. If you gave that little pink weight to someone in their 20s, do you think that would do anything? Would they gain any muscle by lifting that little pink weight up and down? Probably not, because it's too easy. Well, the same thing applies even to individuals well into their 90s. That little pink weight is not enough. It's not heavy enough. We actually need to stress their muscles much, much more than 1 or 2 pounds. And there's actually a lot of research out there that shows that we can push these individuals, these 90-year-old women, men, we can push them a lot harder than that safely, and they can make gains in strength. We can make their muscles bigger. You guys, so my students don't know who this is, but you guys hopefully know who Jack LaLanne is, right? I mean, he's a prime example of, now he maintained muscle mass throughout his entire life, which is kind of, what you want, but he could have, and I bet he probably was able to gain muscle mass, well up into before he died, which, is that a car accident? Did he die of a car accident? Does anybody remember? I don't remember. I thought it was something like that.
So Tyler, do you have, I think back a couple slides it said weight-bearing exercises. So are you coming up with those types of exercises in a slide here?
So there's so many. I don't necessarily have examples, but I can tell you probably one of my favorite and easiest exercises that I prescribe that is weight bearing. And weight bearing is anything that's gonna require you to push or pull against resistance. So most exercises are going to be weight bearing. Now, swimming is not really weight bearing. Is swimming bad? No, swimming is amazing. Swimming is great. People should be swimming. It won't necessarily help with osteoporosis, though, is the point of that. So, but one of my favorite and easiest exercises to prescribe is doing chair squats, getting up and down from a chair without using your hands. So a lot of times I would force people to, clasp their hands in front of them. And you should be able to do that, relatively easily and relatively quickly. Now, many of you guys, that's probably too easy for many of you. Many of my patients were individuals who had a really, really hard time moving, and they may not have been able to get up out of a chair without using their arms. And in that case, that exercise is very easy and very safe, typically, and very effective for them. If that's too easy for you, then there's many other versions. And that's one of the hard parts about giving out really generalized exercises, is that what is applicable to one person isn't necessarily going to be applicable to another. And then you throw in there other things like arthritis and pain. And yeah. Are you familiar with Eccentrics by Miranda Esmond White? It reminds me of the cross. I've not heard of that, but Lisa, but is that like, is it, but it looks like Tai Chi, I'm guessing?
Yeah, she's on PBS, on noon on PBS, and that's how I discovered her. But the exercises are very very fluid, very Tai Chi-ish, and there's some yoga. There's a little bit of, like yesterday, she was actually doing some really easy crunches. So, it's been very helpful to me.
Great. I mean, we need many tools in our tool belt, and that kind of reminds me of one of the most common questions I got as a therapist was, what piece of exercise equipment should I buy? And I say, None. Take that money and put it towards a gym membership, because there are many pieces of equipment and you need many pieces of equipment. You don't need equipment, but if you're going to go the equipment route, variety is the name of the game. And so whether it's Tai Chi or Pilates or yoga or eccentrics, do all of them, alternate what you're doing, because if your body gets in a rut very quickly. If I do the same exercise every day, after about 6 weeks, the benefit of that exercise tends to plateau. That's when we need to increase the weight, increase the number of repetitions, or sometimes even decrease the number of repetitions. We need to vary what it is that we're doing, almost in a way to keep our body guessing, because we have to, we need to continually stimulate our body. And so that sounds great. And then, yes, Leola, I was thinking the exact same thing. The Fit and Fall Proof program through the Idaho Health and Human Services is an amazing program. There's research behind it. It's very beneficial. Yeah. They actually are so popular that it's sometimes, at least in Boise, it's hard to find a class that actually has openings in it. I am currently trying to get some of my students trained so that we can get more classes going, but they can be extremely beneficial. Now, many of you probably, Fit and Fall Proof may actually be too easy. Some of you it may be just right, and that's the thing about exercise. And one of the reasons I hesitate with giving out and showing people exercises, because without the ability to monitor the quality of your movement, it's very difficult for me to determine if that's appropriate or not. Yeah. But yeah, I highly recommend that. So you can go on to, you should be able to Google Fit and Fall Proof, but it is through the Idaho Department of Health. And I think you should be able to go on there and search for different places around the state that hosts those courses. And the people that run the courses go through a pretty strict training, and they know what they're doing. Good questions. So one of the things that we're trying to combat with exercise is this condition called frailty. So this actually is a diagnosis. It's not a disease in itself. It's a condition that usually happens to individuals. And so there are certain criteria. One is unintentional weight loss. The person reports, being, tired or exhausted a lot, like can't go to the grocery store without sitting down and resting, kind of thing. Weakness in certain muscles, like even their grip. So we actually have little machines that can test how strong people can squeeze. Slow walking speed. Your walking speed is correlated with your longevity. People that walk faster live longer. They live longer because people that walk faster tend to be healthier. So there's even some people out there that call it the sixth vital sign, your walking speed. So I tell patients, when if you ever watch a crosswalk, you hit the button and you see how long it takes, for the light to say, okay, walk. There is a calculation that they do, that assumes that you're able to walk at a certain speed in order to get across that street before the walk sign turns off. If you're unable to do that, then you need to walk faster. Oh, we have an instructor. Perfect. Right on. Great. Instructor of the Fit and Fall Proof program. I love it. Love that program. And so, here I'm going to make a guess. I'm going to go back to this picture of this woman. I'm going to say that this woman probably would fall within the category of, or would categorize as having frailty. We see that she's fairly thin, not a lot of muscle mass, clearly has, some compression fractures, so some osteoporosis. Oops. Whoa. Okay. Sorry, I just messed up my slides. Can you still see my screen? Still good? Can still see my PowerPoint? Okay, thank you. So I'm guessing that she is someone who we could say is having frailty. We're trying to combat frailty with exercise, because it's one of the best things for this individual. Because if this frailty is allowed to continue, it's a pretty short trip towards pneumonia, bed sores, not being able to move under your own power. So it would require someone else to transfer you to and from the bed, to the wheelchair, to the toilet, that sort of thing. So if you think someone has frailty, then I would recommend you get them to a medical professional and see if they can get treatment, because that actually can be treated. The opposite end of the spectrum of frailty is going to be obesity. So we definitely have an obesity epidemic in America. So, the obesity is going to, stress our bodies pathologically. It's going to make people age quicker than they normally would. There's increased strain on the joints, which is going to lead to osteoarthritis quicker. We're going to develop diabetes. My analogy for diabetes, my dog is snoring now, so I have to put him down. He snores really loudly and it's distracting. My analogy for diabetes is imagine you're like you're in a water slide, you're going down the water slide on your inner tube. Diabetes would be the equivalent of throwing a bunch of sand in front of you, and then you go down the water slide. That sand, or the sugar, is gritty, and it just causes scraping of all the poor little arteries and the blood vessels that is being spread around, and it can ultimately lead to lack of blood flow to the little tiny nerves that are in our feet and in our hands. And then when we starve these little tiny nerves of oxygen, they go numb. That's how we get neuropathy. That's one of the causes of neuropathy, is actually lack of blood flow to the nerves. And since the nerves are in charge of conducting the sensation, the diabetes tends to obliterate, especially those teeny tiny blood vessels. And that's one of the things that can cause that diabetic neuropathy, which is more likely to happen in someone who's obese. So that's the other end of the spectrum. Exercise and diet obviously can help these individuals. These individuals usually have poor mobility as well. All right, let's go on to the heart and circulatory system. So you've all have seen or have heard of, you've seen the red dress, you've seen the red ribbons that usually represent, heart disease and things like that. Heart disease, #1 killer in America. If you can control your blood pressure, then you're doing really well, because blood pressure is probably, high blood pressure, excuse me, is probably one of the most devastating things that you can do to your body in regards to the heart and the circulatory system. And since it's one of the #1 killers in America, it's probably something to pay attention to. Aerobic exercise is one of the best things to prevent that, especially in men, because now a lot of the research and a lot of the deaths we heard about were associated with men. But what's scary is that women have narrowed the gap. Heart disease is killing almost just as many women as it is men. It's not just a man's disease anymore. It's killing everybody. And so it doesn't really matter if you're a man or a woman. Men do tend to be affected by it a little bit more, but we can use aerobic exercise to combat cardiovascular disease. So aerobic exercise is going to be exercise that's making you sweat. That's, biking, running, swimming, anything that's going to keep your heart rate elevated for an extended period of time, which is different. So far, we've been kind of talking about strength training to a certain extent, strength training, and then balance training with the Fit and Fall Proof program. Balance training and strength training, they don't necessarily elevate your heart rate consistently. They will make you work a little bit harder, but they won't consistently keep it up there where it needs to be. There's physiological benefits that occur when you keep your heart rate that high. And that's what we want to do for these individuals with cardiovascular disease. Okay, so I'm going to kind of tease apart high blood pressure, because high blood pressure is so prevalent across individuals. You can actually have normal, I want to say normal, but you can have blood pressure associated with normal aging. That's how I'll put it. And that's what we call primary hypertension. Hypertension is the medical term for high blood pressure. Primary high blood pressure is due to the natural aging process. It's not due to a disease. It's not due to bad diet. It's just a natural consequence. One of the reasons our blood pressure gets higher as we get older is if we think about that rubber band again. That rubber band is nice and elastic, you know, when people are young, but the older you get, it tends to, it doesn't stretch nearly as well as it used to. It tends to just like be there, and you pull on it and it's stiff and it won't move. Well, if you think of a water-filled balloon, you typically think of a very stretchy water balloon. And that's what a young person's cardiovascular system is like, is a water-filled balloon. It's nice and squishy, and you know, you can stretch it and you know, it goes back to its normal shape. As we get older, that elasticity disappears. So you have a certain amount of pressure inside of the balloon that's generated by your heart. And because the balloon no longer has the ability to expand, every time your heart beats, it spikes the pressure within the arteries. And that causes your blood pressure to be naturally higher. And that's just due to that lack of elasticity. Now, there's a pathological version of that, where a 20-year-old who has a bad smoking habit, who has a bunch of cholesterol, can make their 20-year-old arteries just as inelastic as anyone else's, and they can actually experience hypertension. We've seen children with high blood pressure. I mean, that's how bad the obesity epidemic in America is that little children are given, you know, water pills and high blood pressure pills, which is crazy to me. They should be outside running around and not taking blood pressure medication. But so that's what we will call secondary, or it's disease induced. Many individuals will have a combination of both, but it is the point of my story is high blood pressure is a very common thing because it's a natural part of aging, but it's also associated with many disease processes, which leads to the heart having to work harder. The harder the heart has to work, and this is bad, you know, work. You know, it's working harder in a bad way. The heart, you know, will eventually fail. Cardiovascular disease, congestive heart failure, that sort of situation, eventually. Not right away, but eventually. It can also lead to a heart attack. When you have a heart attack, you scar the heart. If you literally have a scar, just like if you were to cut your skin, when you cut your skin and your body heals it with a scar, the scar tissue is actually different than skin tissue. You put them under a microscope and they're completely different cells. The scar tissue acts much different than the skin. Same thing with the heart. The heart is muscle, pretty much all muscle. And so if you scar the heart, you replace this muscle tissue with scar tissue that sits there and does nothing. And so, which forces the neighboring muscle cells to have to work even harder. And so you kind of get into this, you know, downwards spiral. And there's a variety of things listed on the slide here that kind of happen because of that, which overall leads to the person being unable to get up and walk across the room because they will literally be out of breath because they don't have the cardiovascular endurance in order to do that. That's not a very good place to be. It's kind of like not being able to get up off the toilet because you don't have the strength. Here, you can't walk across the room because you don't have the endurance. Completely preventable. So since I am someone who deals with dizziness, I'm going to throw the dizziness piece in there. We've all stood up too quickly and experienced that head rush where you're like, ooh, you kind of get tunnel vision, feel like you're going to pass out. Individuals with heart disease will experience that on a doesn't necessarily mean they will, but they can experience that on a very regular basis because their heart doesn't have the ability to supply their brains with oxygen. And so they will experience these symptoms frequently. And we're seeing this more and more with COVID, post-COVID patients. So we treat cardiovascular disease medically, so we consult doctors, but then this is also treatable with physical therapy, with exercise prescription. Will a personal trainer do this? No. I would not trust a non-medical professional to do something like this. Anyone who's ever had a heart attack, you may have actually gone through what we call cardiac rehab. Oftentimes it's going to be led by either a therapist or an exercise physiologist, but these are medical professionals who are monitoring the person to make sure that we're not pushing them too hard, but also making sure that we're not, pushing you hard enough, so we need to, make the person work in order for them to recover. Okay, any questions about the heart or the muscles so far? I get on a roll and I just start talking, so feel free to interrupt. We're going to move on to the lungs if no one has any questions.
If someone has had a very severe heart attack, let's say, can you really mend that? Or is it going to be scarred?
There's going to be a certain now, so it depends on, so that's going to rely on the doctor, the medical intervention. So, if you have a heart attack, that person needs to get to the doctor ASAP. If they're able to restore the blood flow to that piece of the heart, then it could potentially recover. If the person, let's say, waits a week before they see their doctor, a week has gone by with some of this heart muscle not receiving any oxygen, and it will literally die, and it will then be replaced by scar tissue. So how much is scarred will depend on how quickly they can restore that blood flow. So anytime, there's chest pain, that gets you to the front of the line at the ER, chest pain, because it's literally a matter of life or death. So even if there is some death of the heart muscle, it's usually just a small piece, hopefully, knock on wood. Cardiac rehab can actually be very beneficial to that person because we can train the rest of the heart muscle, the remaining heart muscle, to work at an increased efficiency. And so if it's working more efficiently, then it actually is able to recover and not go down that road of congestive heart failure like it would normally. Okay. What's really interesting is when you look at a heart under a microscope, heart muscle under a microscope, you take someone who is exercising on a really regular basis, their heart is really healthy, it's really strong. They have stressed their heart, but they have stressed it in the appropriate way. The heart muscle looks very, very different versus you put someone who's had really, really high blood pressure for a really long time. That heart is going to look completely different. Even though that heart was also being stressed, but it was being stressed due to a disease, that heart will actually be very inefficient and will fail because it's having to expend so much energy to accomplish only a little tiny bit of work. Whereas you take a marathoner's heart, it only needs a little bit of energy and it's able to accomplish a lot of work. So we kind of want to get towards that efficiency. And we can do that even with individuals who have had heart attacks. We can increase the efficiency of the heart muscles. Yep. And that's going to be a combination of medication typically and lifestyle change and exercise. It can be successful. It all depends on the person though, because usually what got the person to that place of a heart attack in the first place is usually a lifelong habits. Now, not always. There's, you hear stories of, people in excellent health having heart attacks, and that definitely happens. But by and large, we see poor lifestyle or high cholesterol usually associated with heart disease. Good question. How does genetics play into high blood pressure? Good question. I think more in this is my opinion. I think because we see the genetics is involved with the aging process, I think some people's arteries will naturally stiffen sooner than others. Not because of a disease, but just they lose that elasticity. It's kind of like, some people get wrinkly skin faster than others. If you take the sun out of it, right? Because the sun will make it wrinkle faster. But if you take the sun out of it, some people are just going to naturally, get wrinklier skin earlier than others. And when genetics are involved, there's usually about 50 different variables that lead to something as simple as hair color, let alone blood pressure. So there's so many variables in our genes when we're talking about something like blood pressure that it's difficult to say. But it definitely is influenced. We see that with many diseases. Parkinson's is a really good example. I just recently had an uncle diagnosed with Parkinson's. Parkinson's isn't really genetic, but having a family member tends to increase your likelihood of having Parkinson's. And that's true of almost any disease you can talk about. It's not outright genetic, but genetics tend to play a factor to a certain extent. Oops, went too far. Okay, so we're talking about elasticity again. So now instead of muscles and ligaments and tendons elasticity, or arteries elasticity, we're going to talk about your lungs elasticity. The exact same concept applies to your lungs. It takes energy to breathe in. You're actually contracting your diaphragm as you breathe in, which takes energy, it takes muscle to do. But then when you exhale, you're just relying on the elasticity of your lungs contracting back together to push the air out of your lungs. When you're sitting and doing nothing, or even when you're just walking around, you're relying on the natural recoil, the elasticity of your lungs to breathe out. As you get older, elasticity goes away. And you actually then have to start expending energy to force air out of your lungs. So we see that efficiency thing come back again. When you have to expend more and more energy to do the same thing, it can lead us towards, more deficits later on. Other things that tend to happen as we get older is we lose the strength, which we already talked about with our muscles. We also lose that cough reflex. If you've ever, I've heard this because I've worked in a hospital many times, but if you ever listen to someone cough and they cough really wet, but they cough like this, that's sometimes all the strength that they have to do. And you just want to like almost cough for them because you can hear the fluid in their chest. And you just know that if they were to cough harder, they'd be able to kind of clear their lungs a little bit. That becomes harder and harder, though, with some individuals, sometimes due to age, sometimes due to the disease process. But when that cough reflex is decreased, you tend to keep that fluid in your lungs, which leads to pneumonia. Pneumonia is a huge, huge problem for a lot of people. You see a lot of people admitted to nursing homes simply for pneumonia, because the pneumonia prevents them from being able to get up and walk around the room, to live independently, etc. So the work of breathing, so the amount of energy it takes to breathe actually increases pretty significantly, 29% between the ages of 20 to 70. And that's just with normal aging. You put smoking on top of that now, and you're gonna, up that number even more. Same idea as cardiac rehab. There's pulmonary rehab. There's therapy for the lungs. We can actually get people more efficient at coughing. We will teach people how to cough. It's kind of funny, but we will do it. And we can teach people how to keep their lungs clear, how to do breathing exercises. We can increase the strength of their lung muscles to make them more efficient at breathing. Many kiddos will have, some form of, bronchitis. As adults get older, you've probably heard the word COPD, or the acronym COPD, I should say. And that's where it becomes difficult to get rid of your air. People's lungs will fill with air usually, but when they try to exhale, their lungs tend to kind of almost, the little bronchioles and tubes tend to collapse, and the air gets trapped in their chest, which makes it very difficult to exchange oxygen efficiently because air is literally trapped in the lungs. So we can help with therapy for that as well. So that's going to be very similar to cardiac rehab. So medical consultation along with some exercise. There's also going to be pretty significant lifestyle changes in there because I've only seen a few patients in my life that had COPD that didn't smoke. So usually if you're seeing COPD or emphysema, especially, it's generally associated with smokers. One of the individuals I saw who wasn't a smoker, I think for 40 years worked next to people who were chain smokers. So I guess even though he didn't smoke, he was exposed to smoke on a pretty regular basis. Okay, on to the neuromuscular system. Any questions about lungs? Lots of lung therapy going on with COVID right now. Many therapists. Okay, and the neuromuscular system. So if you're thinking stroke, if you're thinking multiple sclerosis, I talked about Parkinson's disease already. All of those things are going to be falling within this category of neuromuscular system. So it's our brain's ability to communicate and use our muscles, but also use the sensory information that we're getting so that we can make coordinated movements. This morning I was at the dentist. I had a lovely filling in my mouth, and so half my face was numb. And when you have numbness, it's very difficult to have coordinated movement because coordinated movement is dependent on your ability to feel. And when you can't feel your mouth, or your lips, I should say, it's very difficult to talk intelligibly. And so I was mumbling a lot this morning, but fortunately about an hour before this presentation it wore off. So it's all good now. We do see effects in cognition as we get older. There's what we call the crystal memory that increases over time. And it keeps increasing as time goes on. And that's the, you learn, you become smarter as you get older. You learn more things, you learn more facts, you learn more phone numbers, you learn more, you read more books, et cetera, et cetera. That kind of aspect of cognition continues to increase. Now, the fluid memory or the kind of response time, that normally dips off. And the processing speed does tend to decrease, but that's a normal thing. It's very normal to have word finding abilities, or I should say, word finding problems to a certain extent as we get older. And that's to be expected. Now, other things can greatly impact our cognition and that fluid kind of operating, and disease processes can definitely be a major culprit. About 30% of individuals over the age of 30 have some impairment in their cognition. We see a lot of what we call delirium in individuals who have been admitted to a facility. Now, delirium, there's delirium and there's dementia. Very, very different things. I think we've all heard about dementia. Dementia is a permanent and relatively gradual decline in someone's cognition. Okay. Delirium is temporary. Delirium is very common when an individual has to spend the night in the hospital, or maybe the first night or few nights that they spend in a nursing home, they become what we call delirious. And my grandpa, who was very, very cognitively with it, experienced delirium. And we don't exactly know why, but we think it's pushing the person's coping mechanisms to the max, and their brains just kind of like stop functioning for a while because they're in a new environment, they're stressed out, and they're not sleeping. They may not be eating or drinking the way that they normally would be, and so things just get off. Good thing about delirium, though, is that it returns to normal. Like I said, it's temporary, but it's very common to see pretty severe cognitive deficits in individuals when they are first admitted to a hospital or first admitted to a nursing home. So if you're ever visiting a family member and you go and see them at the facility and they're just not with it, and you're like, wow, something is wrong with this person. That's to a certain degree, some of that is expected because it's simply from being in a new environment, let alone, if there is another disease process going on. So cognition is a very, very complex thing. What's really interesting is there's other, at the bottom here, I talk about motor memory or muscle memory. You learning how to ride a bike. So many people know how to ride a bike, and you get to a certain point where you don't have to think about riding, you get on the bike and you do it. And that's what we call motor memory or muscle memory. And that lives in a different part of your brain than the part of your brain that's responsible for remembering things like phone numbers or what day it is or what your name is. And so even people with very severe dementia or Alzheimer's, we can actually get them better at doing physical tasks, not necessarily riding bikes, but we can get them to do things like being better at walking, being better at moving, and being able to take care of themselves because we're able to leverage this idea called motor memory, because it's not affected by the Alzheimer's the way other aspects of memory are. So a lot of individuals with Alzheimer's, even though they may not remember me ever, period, I can actually train them to get better at certain physical things because that piece lives in a different part of their brain. Other aspects of neuromuscular, so this is more of a sensory portion, which many people never even think of, is our vision tends to lose the contrast as we get older. We lose the ability to contrast between blue and green, but we also lose that contrast, especially when it's really bright out or when colors are very close in hue or tone. So on the left versus on the right, putting that yellow tape on the stairs, one of the main reasons we do that is for people with low vision, they can actually distinguish where one step is and another step isn't. Because if you had kind of squint your eyes, you have no idea where is the step on the left-hand side picture. So it can be very, very anxiety provoking for some individuals to function in environments where there's not a lot of contrast. We advise people when they are considering their chair and their carpet color, if my chair upholstery is the same as the relatively close to the carpet's color and pattern, the person may actually not know where to put their butt, and they may actually fall because they tried to sit down where the chair wasn't. And it can be that severe sometimes. And then there's, you add into it cataracts or any other sort of, blindness. Many people with diabetes tend to have problems with vision. Then there's, macular degeneration. And the other one, I figured out, I'm having word finding abilities, word finding troubles. But there are a variety of different eye conditions that can decrease your sight.
How about glaucoma?
Glaucoma, thank you. Glare becomes really problematic, especially with, I mentioned the Oh boy, the cataracts. I mentioned the cataracts. When you get that white film over the front of your eye, it's like driving with a dirty windshield going into the sun. You can't see anything. All you see is your dirty windshield. Same thing happens with your eyes. So we do recommend when we're working with patients, we have certain size font, we have certain things that are contrasting, mostly for our forms, but something to consider. Other interesting things with vision is they did a study where they blindfolded a bunch of young people and they stuck them in the room and they watched them walk. And I think they didn't really tell them like the floor is clear, maybe it's not clear, it's hard, we don't know. But they blindfolded these young people and they had them walk. These young people naturally picked their feet up higher because they were anticipating coming to an uneven surface, or they were afraid of tripping, essentially. Now, when you walk slowly and pick your feet up high, you essentially are standing on one leg for just a split second. One-legged stance is a pretty high level function. You have to, have pretty good balance in order to balance on one leg for any period of time. When they did the same thing for older adults, the older adults actually did not do that. They kind of tended to shuffle a little bit more, and they avoided one-legged stance because one-legged stance is difficult. And so they knew it was difficult, and so they spent less time on one leg and they kind of shuffled instead. We've all kind of seen people walk around in that shuffling manner. And that is a huge, huge fall risk. People that kind of do that, they will eventually catch their toe on something and they will trip. Walking in that little shuffling manner, you burn, and I'm making this number up, but I'm going to say you burn twice as many calories as you would if you were to walk normally. Normal walking is very efficient, and you might we use a lot of the elasticity, and we use our arms and our legs like pendulums, and they help kind of maintain our forward momentum. But if you kind of like shuffle along, you never develop any momentum, and so you have to expend way more energy to go the same distance, which is a huge problem usually because these individuals already have efficiency issues, and they probably already have difficulty with their endurance and difficulty with their strength. And then if they don't walk in an efficient manner, they're really going to decrease their mobility overall, and they're not going to be able to function independently or on their own for very long. So we encourage balance therapy. There's a lot of indications. There's a lot of reasons to seek out balance therapy. One of them I talked about, inner ear problems. There's other red flags. You get one fall a year, and that's it. If you are falling more than once a year, you need therapy for balance because something is going on that's causing you to trip and fall. If it's your dog, you might need dog training as opposed to balance therapy, but still, even like near falls. So I didn't quite fall, I caught myself, I used my furniture. If you're having multiple near falls, I would still consider that to be a red flag and therapy is needed. Or if you fell once and got hurt really badly, you need therapy. Because usually we have protective reflexes that prevent us from getting injured when we fall over, but some people will just fall over and then hurt themselves. And so usually those individuals need therapy. Another one is if someone walks, when you watch someone's feet when they're walking, usually they're fairly close together because that's good efficiency. But if you see someone walking and they're walking with this really, really wide stance, that's kind of because they're probably afraid of falling and they're at an increased fall risk. So I would recommend them to therapy as well. What's crazy, being afraid of falling gives you a fall risk. It sounds crazy, but having fear of falls means you are at risk for falls. So the more confident someone is, actually the better they are, the better the balance tends to be. Most falls are going to occur at home. That's where we spend the majority of our time. So especially with COVID, I think we all spend way too much time at home. I talked about gait speed or walking speed. It's associated with your longevity. So definitely try to keep that walking speed high or normal. Some people naturally walk fast, and those people are more likely to live longer.
What does GAIT stand for? Gait speed?
Gait is the medical term for walking.
Okay. All right. That may be
Or if you're an equestrian, you talk about the gait of a horse. So yeah, it's the way we walk. Yep.
Okay.
Sorry, this is me sometimes forgetting that not everybody knows my medical terminology. Thank you. People that are at risk for falls, so that fear of falling tends to lead to decreased activity. They sit in their recliner, like, well, I'm not going to, if I don't move and if I don't walk, I'm not going to fall. Well, that leads to many other problems. Isolation, mental health. Mental health is such a huge problem right now. I have a lot of students that, may benefit from mental health services because college is tough. You can't find mental health professionals right now. They are like maxed out because so many people are in need of mental health services. It's a little bit challenging to find them right now. So don't let that happen, because that's one of the reasons. Don't become isolated because you're not going to be able to find a mental health professional. No, I'm kind of, that's tongue in cheek, but we don't want people to get to the point where they're isolated because of their fear of moving, of leaving the house, whatever. It's not just getting old. It's not just getting old. That's a false statement. We can do something about it. Hearing. I used to manage a hearing and balance clinic. So there was a therapist that we would deal with balance and dizziness, and then there were the audiologists who would test hearing and fit people with hearing aids. So one of the most common things that we are going to deal with is what's called presbycusis. Presby means age-related, so it's age-related hearing loss. There's definitely noise-induced hearing loss that happens when you work on a helicopter engine in the military for 20 years without hearing protection. That noise is just going to destroy your hearing. But there's also a certain amount of loss of hearing associated with age, and that's because we have these little tiny hair cells. They're different than this kind of hair on your head, but there's these little tiny hair cells in our inner ears that tend to die first, and usually we lose those high tones first, so the high pitches, and people then get into that. They start saying the things like, I can hear, I just can't understand. That's a hearing impairment. So people say, oh, I don't have a problem with hearing, I can hear just fine, I just can't understand what people say. You have a hearing problem. If you're saying that, you have a hearing problem. Sorry to break it to you. Because the first part of that hearing loss is kind of like the vision, and you kind of lose that contrast. You lose the ability to differentiate between certain words and other words, and certain sounds and other sounds. And you want to go get a hearing test. If you have Medicare, you get one hearing test a year. Medicare pays for it, so might as well use it. Unfortunately, Medicare does not pay for hearing aids, but if you have an Advantage plan or other private insurance, a secondary insurance, they might have a hearing aid benefit. So, but there are certain things that you can do to kind of mitigate the hearing loss, even if you don't have or want hearing aids. There are certain things you can do to kind of increase your ability to understand, not just hear, but also to understand. Louder won't always help. So it's a pet peeve of mine when people start screaming at the person that they think has a hearing loss, and it can actually just exacerbate the problem, and the person hears less than. Sometimes you actually have to modulate the tone of your voice, and it's sometimes hit or miss, but you want to be facing the person. We actually do a lot of lip reading. high tone loss. Oh boy, we have an audiologist in the house or a speech therapist, one of the two. Geneva. Audiologist. I was right the first time. So you should be talking about this, not me. But I stole this from pamphlets from my audiologist coworkers. You want to be facing the person because we actually do a lot of lip reading, and if the person can match, what how your lips are moving with the sounds that you're making, usually they're going to be more successful at interpreting what it is that you're saying. Cut out the background noise. I love my mom, but my mom loves to talk to me on the phone while she has her TV blaring in the background, and then she complains about me not being able to hear me or understand me. It's like, well, Mom, I can hear your TV like perfectly well over the phone, so maybe you should turn that down, and then you could hear me a little bit better. And sometimes the pace of your speech could be possibly a little bit slower. And those things can sometimes help an individual with hearing loss. Even if they have a hearing aid, my grandma has hearing aids. Her hearing loss is so severe. I need to do all these things, even though she has a hearing aid still because of the severity of her loss. There's a lot of research out there. I'm jumping ahead. There's a lot of cool devices out there now where you can actually link your cell phone with your hearing aids. So if someone calls you and you can beam, through Bluetooth or I think other methods, you can get the audio of the person on the phone directly into your ears using your hearing aids, which is really cool. You can do the same thing with a microphone. If you have a spouse, you can, or if you have another person you want to talk to, they can wear a microphone that will go directly to your hearing aids or to the TV. You can have a TV link, so the TV's audio goes directly into your hearing aids. Lots of really cool technology. I can't keep up with it. I would recommend talking to an audiologist. Oh, one thing I don't have on here, I thought I did. So there's lots and lots of research correlating hearing loss with, or I should say, uncorrected hearing loss, prolonged uncorrected hearing loss with dementia. When you take away someone's ability to hear, it oftentimes limits their ability to interact with other humans. And that tends to kind of just decrease the overall stimulation of the brain. And we know that people, the lower stimulation of the brain tends to let the brain get lazy, and we do see some dementia associated with that uncorrected hearing loss. Geneva says, lighting is important as well. I didn't think about that. Don't stand with a light behind you and speaking to the hearing impaired. Yeah, so they can see your face. Thank you. And I believe Dr. Gabriel Bargan is she doing some New Knowledge Adventure talks? I want to say she's a coworker of mine. She's an audiologist. She's amazing and smart. I thought I saw her on the list for future topics. That could be wrong. Okay, any questions about neuromuscular? That was a really, really brief overview. I've only hit a few points that I thought some people may not know about. There's many, many, many other aspects to the neuromuscular system and aging. Your neuromuscular systems are probably decreased and you're probably ready to fall asleep, like my students are after an hour and 45 minutes of my lectures. So you're not alone if you're getting tired. We're almost done. Skin. That's my last segment is on the skin or the integumentary system. So you're more likely to get sunburned as you get older because you have less and less skin pigment or melanocytes, which are the cells that produce the skin pigment. And so the chances of experiencing skin damage go up the older you get. We also, and we see, this is common in line with our theme of less hydration. Our skin produces less oil, and because there's less oil, water evaporates out of our skin much easier, much more quickly. So it leads to much drier skin. Drier skin is less healthy skin typically. It's more likely to crack, it's more likely to tear, and it becomes a lot easier to irritate and a lot harder to heal. And so, many people, if you are used to regular daily bathing, the older you get, you need to begin to rehydrate your skin with, lotions or emollients to make sure that you're not, because every time you soap up and wash your skin, you're stripping off even more oil. Well, if your skin's not producing enough oil as it is, that could potentially lead to irritation. And so, making sure that you're keeping the skin nice and hydrated and moisturized. We lose a lot of what we call our subcutaneous fat. So, if you pinch your skin, just under your skin is a layer of fat. Now, that fat is different than the fat that's like inside of your tummy, inside your gut, around your organs. We tend to lose that subcutaneous fat. And I've worked with quite a few individuals under the soles of their feet. They actually lose so much fat under the soles of their feet that it hurts to walk. It becomes physically painful because it's literally skin and bones under their feet. And that lack of padding, makes it more likely to, experience pain, like when you're walking, or if you're, hopefully not hospitalized, but if someone ever becomes hospitalized and they're laying on their backside or even whatever position it is, they're more likely to get bed sores because there's much less cushioning between the hard bones and the firm mattress or whatever it is that you're lying on. Bed sores are 100% preventable. They should never happen, but they happen all the time. And it's really unfortunate, and they can really, really be bad because they get infected. They can lead to a lot of complications. Interestingly, I found it interesting, especially in the old range. So people that are, let's say, over the age of 85, we see an alteration in the drug metabolism. So when you take a bottle of aspirin or a bottle of ibuprofen, it says, okay, an adult take this much, a child take this much. There's a push in, I believe, the medical community for, if you're over the age of 85, you should actually be consulting with your pharmacist or your doctor about what dosage should I be taking, because of the differences in fat content and just other physiological metabolism. Older adults tend to keep medication in their systems longer. So and that can be dangerous, and that could potentially lead to, I don't want to say overdosing, but the dosing may need to be adjusted the older you get, especially if you're someone who is losing a lot of this subcutaneous fat, because a lot of drugs are metabolized in, I don't want to say in the fat tissue, but lack of fat tissue will affect your drug metabolism. I'll put it that way. And so we've seen some people where they're an 85-year-old adult and they take a certain amount of take a certain dosage, it can actually be too much. But I'm not a doctor, I'm not a pharmacist, I'm not telling you to change your medications. I'm just saying that there is a push out there for some individuals. And the number of medications that people are on is pretty staggering. It's very common for, oh gosh, do I have it on here? I don't remember if I'm pulling this from another slide or not. I want to say the average older adult is on somewhere between 7 and 12 prescriptions. That's a lot. And that's the average adult. And I forget the number, the actual number, but I believe it's somewhere between 7 and 12. Each of those drugs, can have this, have side effects, and each of those drugs can interact with another drug. And we don't always know how those drugs interact together. And so you can kind of get some interesting side effects when that many medications are combined. That many medications can, lead to other issues. So one of my plugs for physical therapy is that if you can control disease processes using exercise, diet, activity, you would ideally lessen the need for medication, which always have side effects. hopefully the person would be a little bit healthier if they didn't have to deal with as many side effects of medications. Other things, individuals with diabetes, because diabetes becomes more and more prevalent the older we get, one thing to look out for is infections. Many individuals with diabetes, they can actually have an infection, but they're not going to display a fever, redness, pain. The same is actually true for heart attacks. We call them silent heart attacks. Individuals with diabetes, especially if it has a history of being uncontrolled, they can be having a heart attack and have no idea. There's no chest pain, there's no, there's other symptoms. They know something's wrong, but there's no chest pain, which is usually what people associate with heart trouble. So that can be a little bit of a scary situation, because the signs of infection or the signs of a heart attack aren't there, which ultimately lead to delayed care or the delay in the person seeking care, which can have negative consequences for that person later on. We've talked about numbness in the feet, very common in the hands and the feet, because that's where our feet are the farthest away from our heart, and they have some of the tiniest blood vessels, and they tend to become numb first, because those are the tiny little blood vessels that are damaged before the others. And when you have numb feet, it's kind of like having a numb face. Numb feet lead to potentially clumsiness, balance disorders. People will literally have a sore on the bottom of their foot and they will have no idea. We teach people to always wear shoes in the house. If you have neuropathy, you always need to be wearing shoes, and you need to be taking a mirror, and you need to be looking at the bottom of your feet on a daily basis, because there could literally be a nail in the person's foot and they wouldn't know it unless they looked at the bottom of their feet.
Are you going to go into what a person can do for, when this neuropathy does start and then it gets progressively worse, and then you see so many advertisements about it, we can cure this? But is that everybody, or is that just certain people at a certain time of the neuropathy?
Well, in general, anytime you can catch a disease process, the earlier you can catch it, the better, in general. So that's a loaded question. There might be treatment if you catch the if you catch the neuropathy right away. Well, we have to kind of ask the question, what is causing the neuropathy? If it's uncontrolled diabetes, then the name of the game is controlling the diabetes, and then the neuropathy should hopefully resolve itself. If the neuropathy has been there for many years, chances are we're not going to do much to reverse it. And there is maybe some anecdotal evidence of like these infrared lasers that can kind of, we do know that they can induce vasodilation, so they can increase blood flow to the feet and possibly increase the healing of these little tiny nerves and restore them. The longer you have neuropathy, the less and less likely I think that's going to happen. And so if you're seeing advertisements for like, I can cure your diabetes, like, be careful. That kind of sounds like quackery to a certain extent. But where therapists are really going to be spending most of their time is, what do we do about the neuropathy? What can we do to prevent it from getting worse? And that's usually diet, exercise, making sure the blood sugar is controlled. And then how do we get the person's balance better with someone who has neuropathy? Because if you have neuropathy, I, as a physical therapist, don't necessarily have the ability to take it away, but I can teach you how to balance better despite the neuropathy, if that makes sense. And there's many strategies for doing that. Yeah. Oftentimes it includes a cane. Oftentimes it includes having an assistive device, because our balance is dependent on three main sensory systems: our sense of vision, our inner ears, which is our motion detector, and then the sense of touch in our feet. And it also kind of includes our joint, or what we call proprioception, or the sense of our joints. Like, I know my knee is bent right now. I know my hand is closed without looking at my hand, right? I can sense what my hand is doing without looking at it. When neuropathy is involved, the last one kind of goes away. I don't necessarily feel where my feet are. And so I can't feel the ground. I can't feel the ground anymore with my feet, which is really important in balance. So I replace the sensation of my feet with the sensation of my hand. If my hand is holding on to a cane, I can touch the ground using the cane. And I can actually sense where the ground is using the intact sensation in my hand. And that's actually one of the main purposes of a cane. Or I recommend hiking poles a lot. People are way more likely to walk around with a hiking pole than they are with a cane, for whatever reason. I think there's a stigma attached to the cane. But that's one of the strategies that we might actually use for dealing with the neuropathy in the feet. So look at the bottom. If you have numbness in your feet, you need to be looking at them. Take a mirror, look at the bottoms of the feet. You don't want to nail them. When we get into the complexities of things, this is kind of more of in a way, the slide is designed for medical professionals. The more diseases you get, the more complex things are. So we call this synergistic morbidity. If I have hypertension, if I have high blood pressure, diabetes, 8 medications, a pneumonia, a bladder infection, I am more sick than just the simple sum of those, diseases. It's almost like those diseases get together and they have a multiplicative effect. They have a synergistic effect, and I'm extremely ill. And we see that a lot. And so if we can reduce the number of diseases individuals have, we can keep them a lot more functional. We have to be very careful about pinning everything on one problem. So in the individual I just described, if we only focus on the diabetes, the person's bladder infection and their pneumonia aren't going to get better. But we tend to become so narrow focused on one thing, we have to look at the person as a whole. Unfortunately, you can see this series of events that occur. You have an individual living at home. All of a sudden, they get, I have seen bladder infections hospitalize people and prevent them from living independently, because they are just teetering on the edge of their coping mechanisms. And that's what we call an unmasking event. An unmasking event means one little tiny event kind of, is the literal straw that breaks the camel's back, and the person's unable to function anymore because of that, straw breaking the camel's back. Yeah, anyway, most of this is more for other health professionals. So, okay. I've got a question. Yes. I can put I'll put my contact information in the chat. There's my email, and Marie has it, and Sheena has my email. I do this, I think I tried it. This is the second time I've done it, but I think my intent is to do it as often as you want me to. Every year, as often as you want me to do it.
Great. Does anybody have any questions for Tyler at this point? I know he put his email in the chat. If you want his email and you think of something down the line that you want to ask, you would be able to do that personally through his email. He's agreed to that.
I didn't get your email address.
Are you looking in the chat right now?
No, chat's disappeared.
Oh, okay.
Okay, let me do that. I can
There
do this too. Give me 2 seconds and I'll put it up on the main screen as well. And stop share. I'll do a different share. There. Hopefully you can see that as well. So it's just my name, my first and last name put together at isu.edu.
Thank you.
You're welcome. And I'm in Boise. I'm on our Meridian campus at ISU. And we do have a clinic on campus, but if you know of anyone who has a neurological disorder, like a stroke or Parkinson's or multiple sclerosis, we typically do recruit volunteers to work with our students for our students to kind of practice doing what we call like neuro rehab on these folks. If anyone knows of anybody that would be interested in working with our students, let me know.
So we'd like to thank you, Tyler, for taking the time to go through all of these pieces to your presentation, which I'm sure there was something, excuse me, something for everyone with all the differences that you went through, I should say, on the parts of the body.
Sure. Yeah, no problem. Thank you guys. Thank you for your comments. I appreciate them.
And just so everyone knows, this presentation has been recorded. So we will be putting this up on our, we do put these on YouTube. So if you know someone who missed it, but you think they'd benefit or they'd like to hear it, it will be there probably by tomorrow. And someone else can take a look at this and gather the information too.
Now we all need to get up and move because we've been sitting and staring at a computer for 2 hours.
Yes, exactly. Well, thank you
My
again
butt is
for all attending. And we do have classes through May. So if you have signed up for others, thank you. And if you would like to sign up for any others, you can sign up all the way to the day of the class. And we would send you an email with the Zoom link on that day. So if something occurs and you want to get on a class, feel free to do that. Other than that, thanks again for being part of the New Knowledge Adventures class today. And thank you again, Tyler.
No problem. See you guys later.
Everyone, appreciate your time.